All right, so I'm going to do an audio recording for these slides. Now, I want you to understand something. There are certain slides I will not say anything on. Some of those slides you will just read. Some of them we're not really going to focus on. But that being said, you do have the slides to read separately. If I do not speak on a slide, it will not show up in this video. So you'll see it kind of fast forward a little bit to whatever slides I'm speaking about. So keep that in mind as we're going through this. And of course, if you have any questions, you can always feel free to ask me during the live lectures. So the prime mover is the muscle producing the major force for a specific movement. So an example would be if we're doing flexion of the forearm, the biceps would be the prime mover. An antagonist does the opposite action of the prime mover. So in that instance of forearm flexion, the triceps would be the antagonist to forearm flexion. Now if we switched it, and we did a forearm extension, right? Then the triceps would be the prime mover and the biceps would be the antagonist. So keep in mind these are comparative terms to a movement. So you can't say the biceps is a prime mover. It's a prime mover for flexion, but it's an antagonist for extension. A synergist is a muscle that aids the prime mover in that specific movement. So using that example of forearm flexion, the biceps is the prime mover. You have a muscle called the brachialis, which is a synergist in forearm flexion, and you have the brachioradialis, which is the same thing. It's a synergist, so it helps in that movement. A fixator is kind of a special synergist, and what this one does is it doesn't help in the actual movement, but it will immobilize or stabilize a bone so that the prime mover can do its action. And so an example of this would be the serratus anterior. When you're raising your arm, it locks down the scapula so that you can raise your arm. Basically let those prime movers do their function. So slides like this I'm going to read kind of fast. This is talking about naming skeletal muscles. Some are named for location, like the temporalis, which is on the temporal bone, intercostals, which are between the ribs. Sometimes they're named according to shape. Delta is a triangle, so deltoid is basically the name of the shoulder muscle that's triangle shaped. You have relative size of muscles, maximus being large, minimus being small, longus being long. So those are named according to relative size. We can also name them in the direction of the fibers or fascicles. Remember, the skeletal muscle fibers are the cells and the fascicles are the bundles of fibers. And so if you have rectus abdominis, that's your abdominal muscles in the front there, and those are long, straight fibers, okay? Transversus abdominis, they go across, they go transversely, and oblique, internal and external obliques, the fibers run obliquely. We also see that we can name skeletal muscles according to number of origins. The triceps has 3 origins, and there's 3 heads to the triceps. The biceps has 2 heads with 2 origins, and so keep in mind there's no such thing as a bicep. The biceps, the one muscle, has 2 heads with 2 origins. That's why it's biceps. So you have a biceps on the left and a biceps on the right. Same thing for triceps, except there are 3 origins. Location of attachments, sometimes they're named according to the different attachments. So the SCM is the sternocleidomastoid. It attaches to the sternum. The cleido is the clavicle, and the mastoid, of course, is the mastoid process of the temporal bone. And so that muscle is named according to the attachments. And then lastly, we have action. Sometimes they're named according to their action. If like this, let's use forearm flexors for an example. They're in the front of the forearm, and on the back of the forearm we have extensors. And basically flexor and extensor is in their name, or many of the names of the forearm muscles. Supinator is another example of a muscle that will supinate. So it's basically named for what it does. So on the previous slides, I just want you to read through them and memorize them. But, we have arrangements of fascicles. And remember, the fascicles are the bundle of fibers, so the fibers are going in the same direction. And so like orbicularis oris or orbicularis oculi would be circular. You have parallel fibers. An example of that, sartorius. Pectoralis major is convergent, where the fibers converge into a common tendon. Then you have pennate, unipennate, and multipennate. And so those are some other examples. And so go ahead and read through those and make sure you kind of memorize each of those. You also have the fusiform, which is like the biceps brachii, where it goes parallel, but the fibers go in like a spindle shape. So for the lever system, let's establish the players here. We have the lever, which is the bar, which is going to be your bone. The fulcrum is the point that is a fixed point that we rotate or move around. The effort is going to be the force that is applied to the lever itself. And that's important to make sure we know that the force is applied to the lever, because I'm going to show you later with the third class lever how it can get confusing if we don't focus on that. And then the last thing is the load. That's basically the resistance or the weight. So the first class lever, the fulcrum, is between the load and the effort. Let's go to the next slide and we'll look at an example. I like the example here. You've got, if at the top there, you can see it's almost like a seesaw where the load is going to pull down and the effort has to pull down on the other side to pivot around the fulcrum and balance it out. This gives us our physiological example of the first class lever. So you see, again, the fulcrum is in between, so it's kind of a seesaw type model. And the weight of the head is pulling down the load in front. Behind, those extensor muscles in the neck are going to extend the head back and pivot it around that fulcrum. So basically extension of the neck, the posterior muscles of the neck, that's going to act as a first class lever. Second class lever, the load is between the fulcrum and the effort. Let's go ahead and look at the examples of that. The example I like here is the wheelbarrow. And so you see the fulcrum at the end, you see the load pulling down kind of centrally there or spread out the weight, and then you have the effort you have to push up on that wheelbarrow to pivot it around the fulcrum. Our physiological example for a second class lever is going to be a toe raise or a calf raise. And so if we look on this, we're pivoting around the ball of the foot, which is the fulcrum. The load is central. It's kind of your center of body mass. And then posterior to that is the effort, which is the contraction of the calf muscle. And so we see that the calf raise or toe raise is a second class lever. Our last one is the third class lever. This is the one that gets a little bit confusing, so we're going to look at it a little more detailed on the next two slides. Effort is applied between, so the force is applied between the fulcrum, the pivot point, and the load. Okay, so let's go ahead and look at those. Now we can look at the top example to see the effort between the load and the fulcrum, but let's go ahead and jump to the physiological example and really focus on that mostly for the third class lever. So if you look here, this is a third class lever, so we see that the effort is between the fulcrum and the load. If you look at the load, it's pulling straight down on the hand. The fulcrum is the elbow, the pivot point that we're pivoting around, that fixed point. And the effort, it's done by the biceps, but the biceps, it looks like it's behind the fulcrum there. It's not behind the fulcrum because we're not looking at the biceps for the actual force. It's producing the force, but where's it producing the force on? It's producing it on the forearm. So if you see my red arrow, the arrow on the forearm, that's the actual effort or force being applied by the biceps pulling on that bar of bone. Okay, we could do the same thing for the triceps. The triceps will be behind that fulcrum, but what would happen is it would extend the forearm, and I'm going to put this in blue, so the blue is the forearm going down. Okay, and I'm going to put the arrow up for load if it's like a cable, like a triceps extension. So the blue going up is pulling the hand up. The triceps contracting is pulling the forearm down. Again, that's another example of a third class lever. On this slide, I just want you to memorize that the temporalis muscles and the masseter muscle are the prime movers of the jaw. On this slide, you can see the sternocleidomastoid. And you can see it attaching to the sternum, to the clavicle, and then up to the mastoid, which is not really showing there, but it's on the temporal bone, and you can see it kind of going up towards that. We'll look at the clinical aspect of it on the next slide. So if someone has torticollis, it's essentially when, like if you woke up and your neck is all stiff and you can't turn to the one side, you know, that's torticollis. And it's usually caused by a spasm of the sternocleidomastoid, or this splinting of the muscle. It gets really tight and splints. It's trying to protect the area. Something's gotten irritated there, usually nerve irritation. The nerves that supply the sternocleidomastoid are cranial nerve 11, which is the accessory nerve, and also the second cervical nerve. So if they get impinged for some reason, or they get irritated, it'll cause that muscle to spasm. And so that presents as torticollis. On this slide, I want to talk about the quadratus lumborum. It's the deepest back muscle if you're going from the outside in, from the back, and it raises the hips up and down. And what it does, if it spasms, it can cause some deep, persistent low back pain, and sometimes that's even confused with kidney pain. On this slide, we're looking at the internal intercostals being for forced expiration, and the external intercostals and diaphragm being for normal inspiration. And so the external intercostals, when you breathe in, will pull the rib cage up and out. The diaphragm will push the abdominal organs down. So external intercostals and diaphragm are muscles of inspiration. Internal intercostals are muscles not for normal expiration, but for forced expiration. And then also know that the phrenic nerve supplies the diaphragm. We're going to be talking about that again in the future. On this slide, I want you to focus on the transverse abdominis being the main core muscle. Obviously, there are other core muscles. The obliques do serve as core muscles, some posterior muscles as well. But transverse abdominis is like your body's natural girdle, and it kind of keeps the intra-abdominal pressure, really keeps it really tight so that you can brace when you lift something, and it protects your spine. So on this slide, I just want you to picture the serratus anterior, those prong-like muscles that are kind of on the rib cage there. And what they do is they go back posteriorly and they insert into the scapula. And what they do is they keep the scapula pinned to the posterior thoracic wall of that rib cage. And so when we have a weakness of the serratus anterior, you will get what's called winging of the scapula. The scapula will flare out or wing out because it's not being anchored by the serratus anterior muscle and being pulled up against the thoracic wall. I want to mention on this slide that the trapezius muscle, which is like a big kite of muscle, I'm going to show it on the next slide. That muscle, if it spasms, can cause all sorts of problems, back pain and shoulder pain, things like that. But also it can spasm and cause headaches and kind of pull down on the occipital bone where it inserts into. And so it's associated with some neck pain and headaches, as well as back pain, upper back pain. This gives you the visualization of the trapezius. It's on both sides. This picture is showing it on one side so you can see the muscles underneath. But you can see it goes from the occipital bone to the scapula down all the way down to T12 thoracic vertebrae. You have to memorize certain groups of muscles. The rotator cuff, there's 4 muscles that you've already memorized, but memorize it again or keep it memorized. Supraspinatus, infraspinatus, teres minor, and subscapularis, the sits muscles. Those are your 4 rotator cuff muscles. Remember, there is a teres major, but it is not part of the rotator cuff. This shows the rotator cuff muscles above the spine of the scapula. You have the supraspinatus below the spine of the scapula, the infraspinatus just below that, the teres minor. And if we looked on, this is the back side, if we looked on the front side in the subscapular fossa, that's where we would have the subscapularis. All right, really important stuff here. We have tennis elbow, which is also called lateral epicondylitis. It's inflammation of a tendon on that lateral epicondyle of the humerus, or that attaches to the lateral epicondyle of the humerus. It's the extensor carpi radialis brevis. That tendon gets inflamed, and it causes tennis elbow. This is caused by overuse, or sometimes they call it repetitive use injury, because you're doing something very repetitively, and it inflames that tendon. And that's going to be on the lateral side, right, as we're looking in anatomical position. If we're in anatomical position on the medial side, we have golfer's elbow. That's the medial epicondyle. It's called medial epicondylitis. And that one is a common flexor tendon because there's a number of flexor muscles that insert into there from that anterior portion of the forearm. And that common tendon gets inflamed, and hence you end up with golfer's elbow. And it can happen for a number of reasons, but golfing obviously can be one of them, just like tennis elbow. Tennis can be one of them, but it can be from other things as well. And it's a repetitive overuse type injury as well. All right, this slide shows you, I outlined in purple there, the iliacus that sits in the iliac fossa. I also outlined the psoas major muscle. You can see the psoas minor on top of it, but we're focusing on the psoas major muscle. And the psoas major attaches to the 12th thoracic and all 5 lumbar vertebrae. And then we have it going into the lesser trochanter on the femur. And actually the iliacus and the psoas do share a common tendon inserting into that lesser trochanter. And on the next slide, we'll talk about some clinical stuff with the psoas muscle. So the psoas muscle can spasm. And because it's on both sides, if it happens unilaterally, sometimes you'll get abdominal pain on that side or lower back pain because it can rotate the spine. Even if both spasm, it can cause lower back pain. And another thing that you'll see with the psoas is sometimes when it spasms, it can be severe. And sometimes people think they have an inguinal hernia because it runs over the pelvic brim there. And so it feels like it's in that area where you would get an inguinal hernia. It's also in the vicinity of ovaries, so sometimes it can simulate or mimic ovary pain, and testicular pain because the spermatic cord runs near the spermatic cord and can impinge the spermatic cord, causing pain in the testes as well. So those are some of the clinical aspects for the psoas. This is actually psoas major muscle. It just says psoas on this slide, but it's psoas major. Here's another group you need to memorize, the hamstrings group. It's made up of the lateral hamstring, which is the biceps femoris. The medial hamstrings is made up of the two muscles, semitendinosus and semimembranosus. Go ahead and memorize those. The piriformis muscle is a muscle that runs over the sciatic nerve. So if it spasms or tightens up, it can compress the sciatic nerve. It causes pain down the posterior leg and thigh. And it is probably the most common cause of sciatica. It's called piriformis syndrome. I'm going to show you a picture on the next slide so you can visualize it. So you can see the piriformis there lying right over that yellow thing. That's the big sciatic nerve. It's the longest, thickest nerve in the body. Again, if that piriformis gets really tight, it's going to compress down on the sciatic nerve, causing sciatica. All right, this is another group to memorize. The quadriceps femoris is made up of four muscles. You've got rectus femoris, vastus lateralis, vastus medialis, and then under the rectus femoris is the vastus intermedius. So this slide shows you the tibialis anterior, just lateral to the tibia. And then if this spasms, we'll talk about on the next slide about the anterior shin splints. So anterior shin splints are caused by a spasm, sprain, or tear of the tibialis anterior muscle. So you get almost like a splinting like you saw with the SCM. It tightens up. Now it can actually cause little micro tears. It spasms so forcefully and can actually pull a little bit away from the bone. This is a repetitive stress type injury. So you're getting micro trauma to that muscle. And it's usually caused by, like I said, repetitive stress, overexertion, and there are ways to help prevent it, warming up properly, warming down, using some mobility techniques to keep that muscle from getting so spasmed and flaring up so much. And anyway, that is anterior shin splints, tibialis anterior or anterior tibialis. So on this slide, I just want you to visualize the gastrocnemius, which is the posterior aspect of the calf, and then anterior to that, which is the soleus. They make up the calf group, sharing a common tendon called the calcaneal tendon. Let's look at it from the back view. If we look on here, we can see the two heads of the gastrocnemius. Deep to it and kind of peeking out the side there is the soleus muscle. The soleus muscle is usually pretty thick. That last slide doesn't show it as thick as it usually would be visualized. And let's go ahead and look at, well, if we cut off the gastrocnemius, we can see the soleus. Let's look at that slide. So if we cut off the gastrocnemius, you can see the soleus. They even cut through the soleus on this picture so you can see deeper muscles. However, you can see the soleus does not cross the knee joint. If you go back to the other slide, in your slides, you would see that the gastrocnemius does cross the knee joint. This is going to be clinically relevant on the next slide. Okay, so we said the gastrocnemius crosses the knee joint and the soleus does not. So these are both calf muscles that will basically cause you to, do a calf raise or go up on your toes or the ball of your foot. And the gastrocnemius is more active when the leg is extended because it tightens the tendon. If you flex the knee, it puts slack in the tendon and the gastrocnemius becomes less active. The soleus is the opposite. It doesn't cross the knee joint, so it's more active when you're seated, and it's less active when you're standing because the gastrocnemius is going to be the prime muscle causing that toe raise or calf raise. So let's review this. Gastrocnemius, when the leg is straight, is more active. Soleus is less active. When the knee is bent, so if we're doing a seated calf raise, the soleus is more active and the gastrocnemius is less active. Okay, memorize that.